Would like to begin by thanking you for inviting me. I always take advantage of opportunities to share the word about hospice and the benefits that hospice care can provide. The reason that I titled this presentation "The Hope of Hospice" is because most patients and families feel that when the word hospice comes up, that means that hope is gone. And someone explained to me a number of years ago that if you take the word hospice and you take the letters S-I-C, which is sick, out of it, what you have left is hope. I heard someone last night and have used often and will paraphrase a quote from Václav Havel, which is, hope is not the same as optimism. It is not the certainty that things will turn out well. It is the conviction that no matter how things turn out, it all makes sense. And so my belief in helping to spread the word about hospice is that it is so much more. After over 30 years of hospice in this country, it is so much more than the vast majority of people are aware of in terms of the benefits for patients and families. So we will begin to talk about the hope of hospice. What we're going to look at today is kind of approaches to care as they have existed over the decades. Take a look at what kind of opportunities and experiences of care are available to patients and families, especially in the later stages of disease. We're going to take a look at what the difference is between hospice and palliative care. Those terms are sometimes used interchangeably, and there are some subtle differences. We're going to take a look at myth versus facts when it comes to accessibility of care and who is eligible for hospice care. Looking at the scope of services that are available, not only to patients, but to families. And when is the appropriate time to consider the possibility of hospice care. When we look kind of at the timeline of what happened over the last 100 years, we look at, in the early 1900s, medicine's focus at that time was comfort. There weren't antibiotics, there were not many things that could be done to provide care. People died primarily of infectious or communicable diseases. In 1900, the death rate was 1,700 people per 100,000. People lived to be about 50 years old. Most people died at home, families cared for them, and their disease trajectory was relatively short. Currently, medicine's focus is on cure, and one of the issues that all of you who are here deal with PSP and the disorders affiliated with PSP, is that there is not a cure. So you're not going to walk into a doctor who's going to say, we're going to treat you with this medication and we're going to cure you. But primarily, physicians go to school to become doctors who will cure people and make them better. Most people die today not of short illness, but a chronic illness. 800 people per 100,000 is what the death rate is. Most people are getting close to 80 years old. That's the average length. And when you look at average life expectancy, average says almost 80. That means many people live far longer than that. We will talk through the presentation today about where people spend the last days or weeks of their life, often provided for care at the end by strangers. And the disease trajectory itself is very prolonged. Less than 10% of people who pass away today have a very short trajectory of illness. They're fine, and all of a sudden they crash. It can be a heart attack, it can be an automobile accident, it could be a massive stroke. But the vast majority of people, over 90% of people, die very different kind of death. For people who have cancer, for example, they may have a very stable trajectory, and then as their disease progresses, they may very, very slowly decline over the months or years of treatment and have a very short terminal phase when all the treatments have failed and everything is stopped, and they have a relatively short terminal phase. Other people have a trajectory that looks very jagged, and sometimes with diseases like PSP, you have this, well, you do go along all right for a while, and then you have a crisis. You get hospitalized, we get things stable a little bit, and then you stabilize, but you never stabilize at the place where you were before that hospital stay. And each time that you have a crisis, you come back a little, but you never quite come back to where you were before. So the trajectory continues to decline with these ups and downs, and it's very difficult for families to know, is this the time when the downward trajectory is not going to come back up? So it makes it very difficult for families to make decisions when, well, there have been 6 things in the past 2 years, and mom has always come back. She's going to come back this time. This 7th time might be the time when she isn't going to get better and she isn't going to come back. But that poses a great crisis for families who are trying to make the best decisions for a loved one. There are people who experience a very gradual decline. Oftentimes this can happen with patients who have Alzheimer's disease, where they may not have these major crises, but they just gradually kind of up and down, they're sort of stable, a little bit unstable, but gradually they get to the point that they are close to the end of their life. Currently, what happens in most treatment regimens or plans is we spend all this time either trying to cure or trying to halt the progress of a disease. And when there's a realization that, well, we can't halt the progress anymore, we institute a palliative approach. And then when it gets to be very close to the end of someone's life, I guess there's nothing more we can do, so we will call hospice, and we will have hospice come in to provide care. Ideally, what should happen is that while disease-modifying treatments or interventions are being utilized, there's always a focus, and especially with the kinds of neurodegenerative disorders that we talk about with PSP, that this will ultimately result in the end of someone's life short of a miracle cure that can come up that can either cure the disease or stop its progression completely. There's always that awareness that the condition will continue to deteriorate. So how about we provide that disease-modifying treatment with an approach to care that seeks to provide support at all levels for the patient and family. And because the patient and the family get to this experience of understanding where this is going, they are much more open to the hope of hospice much sooner rather than later in the course of the disease. The state of dying in America today looks very different. A number of years ago, a support study was done. It was called Support, and it really looks at patients' preferences. And it was a retrospective study that was done at a major teaching hospital in the Chicago area, where they looked at the physician's ability to determine a patient's life expectancy, and found that 95% of patients at the time this study was done, physicians, were unable to accurately give a good sense of someone's expected life remaining as short as the last 10 days of their life. In my experience in hospice, I have found that often when physicians talk about a patient having a life expectancy of 3 months or less, those often are the patients that if we have them admitted to hospice with 3 weeks left, we are feeling fortunate. Physicians don't learn about how to be honest with families And they don't learn about what do you do when you can't make someone better, because their whole focus often in going through medical school is to look at ways that they can cure people and make people better. And there is a great disparity in our society today about how patients say they want to spend the last months of their life and what actually occurs. They've done a couple of studies. In one study, they said to people, what would be your desire if you knew that you had a very short period of time to live? 6 months, 8 months, a year. And their desires were they did not want to die, or they desired that they don't want to be on a ventilator. They desire to be comfortable. They want to be with family. They want as much time as possible with their family, and they want to be at home. They did another study and said to people, what are you most afraid of if you're getting close to the end of your life? And what they said is, I don't want to die on a machine. I don't want to die in pain. I don't want to be a burden, and I don't want to be in an institution. So whether you ask the question positively as to what they want, or from a negative perspective, what are you afraid of, the results of the studies look almost identical. When we look at care of patients in the later stages of disease, we see that some of the barriers we encounter is that, as I said, the focus in our country today, we can put a man on the moon, we certainly should be able to fix everybody, and we can't. Whether it is a disorder like PSP or a disorder of heart disease where a heart just gets worn out, or a disorder of cancer where it has spread and no treatment is effective, we know we can't cure people. And I was at a conference once and heard a physician who was a hospice physician say to his colleagues, we have to do a better job of caring for our patients as they get closer to the end of their life, because the reality is, all of you physicians who are sitting out here, all of your patients will someday die. You cannot stop it. And so what we need to do is provide a better focus of how do we improve the quality of their life. Whether it is a physician or sometimes family. The last session we talked about, what happens when the treatment team thinks that a patient is no longer able to live independently, but the family can't make that decision. The same thing happens with medicine. There is a failure sometimes on the part of the healthcare professions to realize that there are limits to what they can accomplish. Sometimes out of the family's sense of loss, they are not willing to admit the limits of what can be done to provide care at the end of someone's life. Healthcare providers need more and more training. There are now palliative care training programs for physicians. Some physician training programs actually send their medical students to work with hospices and palliative care programs to learn what it's like to provide for care for patients when you know the outcome of their disease process will not be that they will get better. About 8 or 9 years ago, an organization began a training program for physicians called the Education of Physicians on End-of-Life Care. And a few years later, a curriculum was developed for nursing students called the End-of-Life Nursing Education Consortium, where healthcare professionals learn the gift that they are able to give to patients and families when cure is not possible. Palliative care and hospice services after all of these years are still very, very poorly understood. And from a reimbursement standpoint, palliative care has no formal reimbursement structure at this point in time. We look at cure, and in some disease processes, it's important to look for cures. It was exciting for me to sit in on the sessions this morning and hear about clinical trials, studies that are being done to look at, if not at this point, a cure for PSP, but a way to slow the progression of the disease with the goal of perhaps ultimately stopping the progression of the disease. We look to alleviate symptoms, and there's much work that's being done for the patients who have PSP How can we treat their symptoms? How can we give them the best quality of life, the fewest side effects, and minimize their effect on their daily living? Physicians and medicine in general have made great strides in the 21st century. We have antibiotics now. People don't die of infections. But the rates of obesity, diabetes, and heart disease continue to grow and continue to rise, and the mortality rates associated with those diseases rises as well. Often today, cancers are diagnosed when spread of the disease has already occurred. And as you all well know, degenerative and neurological diseases have no cure at this point in time. But what we do know about all of us as human beings is that as we age, our organ function naturally declines. And somebody said to me once, how can you work in hospice? Because all of the patients that you work with are dying. And my belief over all of the years that I have worked in hospice is that I could say that about anybody who works with anybody, because the reality is we are all dying. We just don't know it yet. And so my focus is to say I am working with patients who are living, and they are living with our help the best quality of life they can have for the longest period of time. I mentioned the programs that exist at Harvard and Stanford and the Mayo Clinic since the 90s. Physicians today are getting more training, but there are still many physicians who come out of medical school who do not have specialized training. There are programs that actually train and certify physicians in hospice and palliative medicine. And I mentioned the palliative nursing education program that was developed about 7 or 8 years ago. There are subtle differences between palliative care and hospice. Often you will hear people say that the care that is provided in a hospice program is all palliative, from the standpoint that the word palliative means to manage symptoms, to treat symptoms, to improve quality of life. However, from a reimbursement standpoint, not everything that is done in a palliative care environment is done in a hospice environment. Hospice began in England with Dame Cicely Saunders back in 1967. It's where the first hospice program existed. There have been hospice programs in this country since the late 70s, although initially most of those hospice programs were volunteer programs where healthcare professionals, nurses, physicians volunteered their time and provided hospice-like services on a volunteer basis. In about the mid-1980s, someone thought, wow, that hospice model works pretty well. Let's see if we can expand that within a healthcare setting. And the primary difference in focus is that in palliative care, disease treatment still occurs. It can be very aggressive disease treatment. In hospice, the management of symptoms is what is aggressive. So disease treatment is aggressive in palliative care and symptoms are managed. But I often tell families and patients that I work with that hospice is as aggressive as the treatment they have received previously, but our goal is different. We're not trying to aggressively treat a disease. We are going to be aggressive in treating symptoms. Patients and families can access palliative care anytime in the disease process, and they can even use palliative care services if a disease or a disorder is potentially curable. In hospice, hospice is provided when cure is no longer possible, and it is provided in the last months of life. And I stress months because too often patients come to hospice in the last days of their life. Palliative care is usually delivered in an institution or a hospital environment, a long-term care, long-term acute care, by a number of people with very different specialties. Trish spoke earlier in the presentation about the multidisciplinary team. There's nurses, physical therapists, physicians, speech therapists, occupational therapists. Everybody comes to the team with their specific role, bringing their specific expertise. And patients can stay in a palliative care program for a prolonged period of time. With hospice, there's just some nuances. It's called an interdisciplinary team because there is not quite the same role definition. You have nurses, you have physicians, you have a social worker, you have a chaplain, you may have some therapists. Everybody comes with their area of expertise, but they work collaboratively, and there are some crossing of role boundaries. So if as a hospice nurse I'm visiting with a patient, and that patient proceeds to talk to me about some of the spiritual issues that are going on in their life, I may listen to them because I'm there, and then say, it might be helpful to have our chaplain come out to spend some time with you. And then my interaction would be to call that chaplain and say, I was visiting this patient today, and she was very open to have you come and listen to some of her spiritual concerns at this point in her life. So it's a little less formal than that multidisciplinary team that happens in a hospital. And the goal is that because our boundaries cross somewhat, we will be able to hear things from our patients and families and know where to get the assistance. I certainly am not a social worker, and I cannot have the expertise of our social worker who works on our team, but I can listen for things to alert a social worker to the needs that the patient and family may have. Hospice care can be delivered at home, in a nursing home, in an assisted living, on a hospital inpatient unit, and hospice care is delivered wherever the patient lives. So if the patient lives at home, they can be in hospice. If they have to transition to an assisted living facility, they still stay in hospice. If they go on to be in a long-term care facility, they still stay in hospice. So hospice kind of follows the patient along that trajectory, which is one of the reasons why it's so important for us to be able to have the ability to be there to provide support for patients and families so much sooner in the disease process than currently happens in this country. The length of stay in hospice, and I want to kind of explore that a little bit, is 6 months or less if the disease progresses along its normal course. It was actually politicians who figured out 6 months. It was not anything years ago that happened as a result of medical people looking at disease process. They were going to institute the Medicare hospice benefit, and somebody said, well, how about 3 months? No, that doesn't seem like it's long enough. And somebody else said, well, how about a year? And the decision was, let's pick 6 months. That was actually how it came about. But the qualifier is if the disease progresses along its normal course, which means if a patient who has PSP is appropriate for hospice, and the belief is that if I were to look at this patient, it would not surprise me if this patient lived 6 months or less. At the end of 6 months, we ask ourselves the same question. If this patient I were to meet with this patient today, do I believe this patient would have 6 months or less to live? Yes. Then the patient still qualifies for hospice. So the reality is that in fear on the doctor's part often of saying the word hospice, because there is such a negative connotation about, well, it must be just days or weeks. Physicians are afraid to bring up the word hospice, and I have had families say, my doctor told me for my husband that we should be in hospice 6 months ago, and I told him we weren't ready because my husband wasn't that close to the end of his life. And here it was 6 months later, and he was now coming to hospice, and he was with us 4 days. And I remember her saying, I wish I had listened to the doctor, because what you're describing you can do to help me. I could have had all this help for the last 6 months, but I didn't know. So even after all these years of hospice in America, the vast majority of Americans don't know the services that are available to them, that can be provided to them over a long period of time, because they may have known two people who were in hospice for less than a week. And so their belief is, I guess we don't go to hospice till the last week. The reality is, it sort of is like a self-fulfilling prophecy. If that's all you know, that's what you expect. And the more we can get the word out to people that you can have access to hospice services for a much longer period of time, we will be able to provide much better care for our patients and families. Reimbursement for palliative care programs is usually in a hospital setting, philanthropy. Some insurance companies are beginning to be able or willing to cover a palliative approach to care if they can see that when they do this, the patients don't get hospitalized as frequently, so it does in the long run save insurance companies money. Or the support of a hospital. I worked with a hospital that, as part of their mission, developed a palliative care program in the hospital. The frustrating part for me was when those people were able to go home, if they were not open to receiving hospice care, then there was no way to continue that care when they went home. Often I would be called for a palliative care consultation, and the physician would say to me, whatever you do when you go in there, don't you worry about talking about hospice. And so I would go in and I would talk about our palliative care program that we had in the hospital, and inevitably, every 2 or 3 patients, I'd have somebody say, well, that sounds a lot like hospice to me. And I thought, well, there's my opening, because I didn't bring it up, they did. And often, when those patients heard about the care and the services that would be accessible for them and their families, they were more than willing and more than open to consider hospice as an approach to care that was appropriate in the last months of their lives as opposed to the last few days of their life. Hospice is covered by most private insurers. It is covered by Medicare. It is covered by Medicaid. With private insurers, there may be some co-pays involved. With Medicare and Medicaid, there are virtually no co-pays. Hospice care is provided out of the Medicare Part A benefit, and what it covers is all of the hospice staff, the nursing, the nurse's aide, the social worker, the chaplain, the hospice physician. All the equipment that the patient needs to provide comfort: wheelchair, hospital bed, oxygen, shower bench, any equipment that they need in the home or their place of residence to help improve the quality of their life is provided by the hospice at no fee. All of the medications that are used for pain and symptom management are provided at no charge. The hospice nurse orders them, they're delivered to the patient's home. Counseling services through chaplain or social worker, volunteer services, and 13 months of follow-up for family after they have lost a loved one. Phone calls, mailings, opportunities to see how the patient's family is doing as time goes on, getting them through the first Christmas or the first birthday or the first wedding anniversary. So the services are extensive, and I always tell patients and families when I meet with them that unlike most areas of healthcare where the focus is on the person who has the disease, hospice care admits the entire family unit. When we admit a patient, we admit the whole family. The care that is provided in hospice is directed by what the patient and the family tell us that they need. We have nurses who are experts and doctors who are experts, but it is the patient and family who say, here's what we really need at this point, and maybe a month down the road say, now there's some extra things that we need, or some different things that we need. Patients may come on board with very little in the way of equipment, and 2 months down the road, they need additional equipment. So our plan of care, by law, has to be reviewed every 14 days. Our patients that are admitted to hospice have to have the whole interdisciplinary team sit down and say, okay, what is going on with this patient, and what do we need to do to improve this patient's quality of life? And Medicare and Medicaid and the insurance companies require that we have that documentation, so if they ask us for it, we can prove to them that every 14 days we sit down and look at what has to be done. Oftentimes, the plan of care can change every 3 days, depending on what's happening, but at a minimum, we have to look at that plan of care every 14 days. There's many myths still out there. One of them is hospice is only for people who have cancer. And hospice just provides large doses of pain medicine, and all that happens is the patients go to sleep for a few days and then they die. No treatments of any kind are allowed in hospice. Those are all the myths, because in actuality, hospice provides only as much pain medication as patients need. And when we have the ability over a period of time to manage pain, we actually can get patients free of pain and alert. But what happens when a patient is referred very late in the disease process, a matter of 2 or 3 days from the end of their life, we provide them with medications to control their pain, and they don't die because of the medications. They die because they were 2 days away from the end of their life, even if we hadn't been there. Treatments are not allowed. Absolutely, treatments are allowed. Patients get breathing treatments. We have patients who are at home using a CPAP to help with their breathing at home. We have patients who actually may be on a transplant list. We might have someone who, we did have a lady actually with our hospice, who came on hospice while she was on a transplant list to see if she could get a heart transplant. And we could provide care for her right up until the time she died, because she never had access to that heart transplant. So one of the things that we don't want to do is to ever take away someone's expectation or idea that the hope goes away the minute you enter hospice. Hospice is for anyone who has a life-limiting disease. Hospice covers lots of medications to manage symptoms, not just pain, shortness of breath, fatigue, nausea, vomiting, lack of being able to sleep well. Sometimes we use medications to increase someone's appetite. Sometimes we use small doses of medications to increase and improve someone's energy level. And we include things like, as I said, breathing treatments. Some patients get short-term IV therapy. Some patients may develop an infection, and we treat their infection because that's a matter of treating them to make sure that they're comfortable. Myth: once you decide to receive hospice care, you must stay in hospice. That's not true, because I just said you can come in hospice if you're on a transplant list. You must sign a do not resuscitate order to be admitted to hospice. That's illegal. No one can make you sign a do not resuscitate order. Certainly, we encourage all of our patients and families to have discussions about advance directives and what they want done. But we have a pediatric program, and 95% of our parents in our pediatric program never sign a do not resuscitate order. That's a very, very difficult thing for a parent to do. And those children often, 99.9% of the time, die at home in their parents' arms with no worry about a do not resuscitate order. The only time that that do not resuscitate order is critical is if you don't have it and someone in the family calls 911. Then the people who arrive in response to that call by law have to begin resuscitation measures. So the only reason to have it is to protect the patient who does not want to be resuscitated. But if you don't have one and you don't call 911, there isn't a problem. And by law, no one can be denied access to hospice care under Medicare or Medicaid simply because they choose not to sign a do not resuscitate order. And once you're in hospice, you can't go back to your own physician. Lots of people feel like, well, because oftentimes what doctors will say is, there is nothing more we can do for you, I'm going to call hospice, and they never see their attending physician again. And so the feeling is, well, I can't have my attending physician anymore. Many doctors will defer to the hospice doctor because of the hospice physician's expertise in managing symptoms. But if the patient can still get to their primary care physician, they can still see their primary care physician, and that physician works collaboratively with the hospice physician. If you choose to stay with your physician, hospices will work with you so that your physician will continue to be able to bill for those visits. Sometimes physicians may be reluctant to give up the care of their patient because they have a relationship with them and because they know if the patient comes to see them, they won't be able to bill for the services. The reality is they can still bill, and the hospice organization can help them find the way to do that with the correct billing codes. The principles of palliative care and hospice care are very similar. Both approaches talk about families as a unit of care where the goals are developed and planned and implemented collaboratively between patients, families, and the hospice team. Patients and families are involved in decisions, and attention is always focused not solely on what the patient needs, but what the family needs as well. We provide support and education for our patients and families, always going back and reaffirming our goals, making sure that their goals haven't changed, helping to educate them about what to expect as the disease moves forward. And hospice and palliative care, as I said, goes across all settings. The goal is to look at physical, psychosocial, social, and spiritual well-being. The model that we use looks at controlling symptoms, looks at controlling pain, and looks at being a support for the patient and the family. Psychologically, we look at assisting patients and families to deal with all the emotional concerns around a life-limiting illness, whether it's what is the meaning of this illness, issues around depression, looking at coping skills, looking at cognitive assessment. We look at the social family structure and the dynamics that go on in the family. What kind of burden is the caregiver experiencing? Sometimes they get so worn out from focusing solely on the care of their loved one that they stop taking care of themselves. And we're there to remind them that if you become ill, you're not going to be able to take care of your loved one. We look at issues around sexuality, impact on children, whether it's a younger patient with young children, a middle-aged parent who is a patient who has teenagers, or the impact on children when a loving, loved grandparent is severely ill. And we help to look at financial concerns. Our social workers can be out there to help families find additional resources for some of the help that they need in the latter stages of disease. Our chaplains can be out to work with patients and families looking at issues around religion and spirituality, the idea of hope versus despair, and finding out from the patient and the family what kind of rituals are beneficial to them as they take this journey towards the latter days of their life. As I talked about, we have hospice physicians who oversee the plan of care, hospice nurses who provide the interventions and assess what's going on. Most hospice physicians are certified in hospice and palliative medicine. Most hospice nurses go through training to be certified as hospice and palliative care nurses. We have hospice home health aides. There is even a certification in hospice and palliative nursing for nurses' aides. Our hospice social workers and our hospice chaplains, in addition to hospice volunteers who are able to provide a break for a caregiver so they can get out of the house, and the volunteer is there to stay with the patient. We have intensive training programs for our hospice volunteers. We have all hospices by law must provide a bereavement program where they provide follow-up to patients and family members for that 13 months that I spoke about earlier. When is the appropriate time to consider hospice? I believe the most appropriate time to consider hospice is when you find out that you have a disease for which there is no cure. That does not mean you come to hospice at that point in time, but at least get the information about the services that are available so you don't find yourself in the last week or two saying, I wish somebody would have told me about this 6 months earlier. Until we're able to get the word out that hospice does not mean the end, people will be afraid to still have that discussion, whether it's a physician discussing it with a family. But as an advocate for your loved one, ask about getting information. You know, sometimes you'll talk to a doctor and he'll say, well, you're not ready for hospice yet. You can say, I know we're not ready for hospice. I want the information now so we can have the discussion that we may not need to access hospice for 4 years. But when we get to the place where we know it's time, we will have had the opportunity to make the decision not in the midst of a crisis, but in the midst of planning. Just like we talk about advanced directives and advanced care planning, part of what each of us should do is prepare for the fact that at some point we will come to the end of our lives. My husband and I are both very healthy, and yet we have advanced directives, and he knows what I want and I know what he wants. It's not always a comfortable discussion to have, but it's the way that we can give a gift to the person left behind to know that they are carrying out the wishes that we talked about in a very calm, not crisis-filled circumstance or situation. It gives us the possibility of having a plan, having as much information as we can, as far in advance as we can, so we know what all the options are, and having a plan as to how we're going to access those options when it becomes time.
Thank you so much.
Thank you.